Radiation therapy saves lives, but years later, it can quietly reshape the carotid arteries in ways we're only beginning to understand. I'm George Vilanilam, and this is the AJNR podcast. Today, we will unpack an article titled Biphasic Progression of Radiation-Induced Carotid Stenosis, the Predictive Role of Low-Density Plaque, by first author Chung. This article proposes a new framework for how carotid disease evolves after head and neck radiation and highlights an imaging finding we may be overlooking. Radiation therapy is a cornerstone of treatment for patients with head and neck cancer, but it's not without long-term consequences. Among the most serious of these is radiation-induced carotid stenosis, which increases the risk for future stroke. We've known for some time that patients who undergo head and neck radiation have higher rates of carotid artery disease and cerebrovascular events when compared to the general population. What hasn't been as well understood is how this disease progresses over time, and more importantly, how to identify which patients are at the highest risk of total carotid occlusion. So this paper sets out to investigate exactly that. The authors propose a new biomarker, low-density plaque, and test whether it's predictive of rapid progression to carotid occlusion. So the authors aimed to understand the natural history of carotid artery total occlusion following radiation therapy. They also wanted to evaluate whether calcification plays a role in predicting risk, and three, most importantly, to assess whether the presence of low-density plaque signals a tipping point in disease progression. So how was this studied? This was a retrospective cohort study involving about 44 patients with head and neck cancer who had previously undergone radiation therapy and were being followed for carotid stenosis at a single neurological institution in 2021. Patients had a variety of tumor types: nasopharyngeal, oropharyngeal, oral cavity, middle ear, and hypopharyngeal cancers. Those patients with 50% or greater stenosis were treated with antiplatelet agents and statins. Patients with irregular follow-up, no radiation or just recent radiation within the last 2 years were excluded. Patients underwent contrast-enhanced CT scans every 1 to 2 years, and stenosis severity was quantified using the European Carotid Surgery Trial method. The key biomarker of interest, the low-density plaque, was identified by both a neuroradiologist and neurosurgeon independently using predetermined visual criteria with excellent inter-rater reliability. Carotid stenosis progression was therefore calculated before and after low-density plaque detection, and the authors excluded any intervals less than a year to avoid overestimation. And importantly, only patients with complete longitudinal imaging data were included in this part of the analysis. The authors also present a helpful visual in Figure 1, which shows a single patient with nasopharyngeal carcinoma who developed low-density plaque at year 7 after radiation, with stenosis accelerating rapidly from 23% to complete occlusion by almost the 12th year. So this corresponds to a post-plaque progression rate of nearly 16% each year. So the key findings of this study was that carotid artery total occlusion occurred in about 11 of 44 patients, which is 25%, affecting about 12 vessels. The median time to occlusion was 12.6 years after radiation therapy, as seen in Figure 2 in the paper. And before low-density plaque appeared, stenosis was stable, around 0% each year, but after the plaque appeared, progression accelerated dramatically, reaching nearly 15% per year in some cases, as seen in Table 2. And furthermore, by extension, a low-density plaque group characterized by faster stenosis progression. They had a higher intervention rate of about 22% when compared with the non-low density plaque group, likely mitigating the total carotid occlusion risk as seen in this table. And interestingly, neither the age at the time of radiation nor calcification was associated with the risk of occlusion as shown in this table 4. So while we've historically been focused on plaque calcification as a possible stabilizing or destabilizing factor, this study suggests that it's not very useful in this setting. Indeed, it is the appearance of low-density plaque that marks the beginning of a high-risk phase. So, sort of elaborate on this, from a histological standpoint, intimal atherosclerotic calcification occurs when thickening of the arterial intima compromises, local blood supply, leading to necrosis. Now, these necrotic zones then stimulate calcium deposition with inflammatory signaling, converting them into fibroinflammatory lipid plaques. Now, this process destabilizes the plaque and increases the risk of rupture. However, some evidence suggests that calcification may also represent an active bone-like remodeling process initiated by vascular cells. Whether that is stabilizing or not, that still remains unclear. Another layer to consider is hemodynamics. As large arteries like the ICA, the internal carotid artery, stiffen from calcium accumulation, the flow velocities rise. So this increased shear stress may further destabilize plaques and accelerate narrowing, particularly when lipid-rich components like low-density plaques are present. So altogether, this paper supports the idea that low-density plaques on CT, much more than calcification, is a harbinger of aggressive disease, and it gives us a specific imaging biomarker to watch for in long-term radiation follow-up. Overall, I think this study provides significant insights into the natural progression of carotid artery disease in patients with head and neck cancer after radiation therapy. And it introduces this biphasic progression model revealing that low-density plaque detection accelerates stenosis and predicts a high-risk phase. In clinical terms, it means that once a low-density plaque is identified, the risk of occlusion escalates rapidly. So these findings suggests that, intensified surveillance such as annual or biannual contrast-enhanced CT scans and timely interventions, including carotid artery stenting or endarterectomies when patients meet guidelines recommend thresholds. In clinical terms, this means that once low-density plaque is identified, the risk of occlusion escalates rapidly. And these findings suggest that patients may benefit from intensified surveillance, such as annual or biannual contrast-enhanced CT scans, and timely intervention, including carotid artery stenting or endarterectomies when these patients meet treatment or recommended guidelines. Importantly, this study also helps shift the conversation from focusing purely on percentage stenosis or calcium content to paying closer attention to plaque composition and evolution over time. So by identifying low-density plaques as a red flag, we may be able to intervene earlier and potentially prevent catastrophic strokes in this high-risk population. And despite the small sample size and the lack of prospective follow-up and the single-center study, I thought this was a fairly well-done study, especially with its attempt to quantify stenosis progression pre and post the appearance of a low-density plaque. And for those of us reading these post-radiation necks regularly, it is a reminder that plaque quality and not just quantity matters. That's it for this article. I encourage you all to go back and take a look at the complete article in this month's AJNR. Thank you, and see you next time.